Candida, a constant threat. It's a normal commensal on our bodies, and normally it doesn't produce any serious harm. But with the advent of modern treatment and surgeries, it has become fourth commonest isolate in blood cultures in hospitalized patients world across. In the beginning of this century in USA, there was a 52% rise in incidence of candidemia with the use of central venous catheters. And with the introduction of prevention bundles for CLABC, they could decrease it. Still, it remains an expensive affair with $2 billion per year cost to the country. The primary defense mechanisms are intact skin and mucous membrane. There are certain inherited deficiencies in immune system like CARD9 deficiency, which is associated with deep mycosis with several fungal agents. And with Candida, there are manifestations of mucosal and systemic involvement. There is another deficiency which is related with dectin-1, where patient presents with recurrent vulvovaginal candidiasis and onychomycosis. There are several clinical manifestations with mucosal involvement, skin involvement, and deeper organ involvement. It can infect any organ and any prosthetic device. Among mucosal involvement, thrush is the commonest, commonly seen in neonates and AIDS patients. And there is a curd-like lesion, which is a pseudomembrane and which bleeds on removal and is painful. Candida esophagitis is seen with viral infections like AIDS, HIV, severe herpes simplex viral infection and cytomegaloviral infection. Vulvovaginal candidiasis is seen with pregnancy, diabetes mellitus, use of corticosteroids and antibiotics. Interestingly, it is not so severe and refractory in AIDS patients. And at the same time, with the use of antibiotics, Candida esophagitis is not seen. Cutaneous manifestations can be generalized cutaneous candidiasis, usually seen in infants. Interdigital involvement is painful and seen in patients who put their hands in water. Candida folliculitis is seen in obese patients. Candida balanitis can be acquired from the partners. Disseminated candidiasis can manifest as cutaneous manifestations from simple all lesions, macular, papillar to as severe pyogenic gangrenosum. Then intertrigo is seen in obese patients, paronychia and onychomycosis, diaper rash and perianal candidiasis, chronic mucocutaneous candidiasis. It manifests as disfigurement of scalp, nails, and face. Deep organ involvement is CNS involvement, which is seen in, again, neonates and in neutropenic patients. Respiratory tract is rarely involved. One may isolate Candida from respiratory specimens like bowel and sputum, but it doesn't have such involvement, and only if lesions are diagnosed by biopsy, which is very rare, then it should be treated. Cardiac involvement is very common, and myocardium has multiple microabscesses in autopsies. without any the valvular involvement in these cases. Endocarditis, 1 to 10% of infective endocarditis cases are due to fungal isolates, and again among them 67% is due to Candida. Urinary tract infection is quite common. It can be both ascending and descending. Ascending infection is usually associated with Foley's catheter insertion. Osteoarticular infections are again commonly seen and important. Intra-abdominal infection needs to be differentiated from colonization. Candidemia is increasingly seen in ICU patients, and ocular candidiasis is important to diagnose timely and treated. So invasive candidiasis is mainly seen in intensive care units in immunocompromised patients, and this is a new group of patients, intravenous drug users, especially in 18 to 44 age group, healthy adults, and community acquired candidemia. Highest burden is in surgical units, in trauma and burn wards, in abdominal surgeries with pancreatitis, gastrointestinal perforation, and anastomotic leaks. In medical units with high Apache score, diabetes mellitus, renal insufficiency, hemodialysis. Generally, central venous catheter is the single most important predisposing factor. Broad spectrum antibiotic use, corticosteroid use, and total parenteral nutrition. In this study in US, it was found that though Candida albicans is found in 40 to 50% of Candidemia cases, and it is distributed more commonly in general medicine wards, in patients of solid tumors, in surgery, and in AIDS patients, and also in NICU. Whereas Candida glabrata is associated with hematological malignancies, stem cell transplant, solid organ transplant, and Candida parapsilosis is seen in NICU and along with biofilms on plastic devices. The two important predisposing factors for non-albicans Candida infections were use of fluconazole. Candida glabrata is resistant to fluconazole in 80% cases, and Candida krusei is inherently resistant to fluconazole. Now these two agents have got new names, Nicasiomyces glabrata and Pichia kurzos zevi, but we will be using these names to understand easily because these are the prevalent names. Because of biofilm formation by Candida parapsilosis, it is more commonly associated with central venous catheters. So species identification is very important because of their inherent resistance to fluconazole, and Candida glabrata is being increasingly seen resistant to voriconazole and echinocandins. And Candida auris is a new isolate which has been known as fungal superbug, and it is multi-drug resistant to three classes of important antifungal agents, that is azoles, polyenes, and echinocandins. So this is a fungal superbug which is often misidentified and therefore mismanaged. It leads to hospital outbreaks with high mortality. So it behaves just like bacterial multi-drug resistant organism, and good infection control program is required to prevent these outbreaks and increasing mortality in hospital ICUs because it is difficult to eradicate. and it is resistant to quaternary ammonium compounds. So its proper identification and proper management with infection control program is important. There is another similar isolate, Candida parasilosis, has emerged worldwide with fluconazole resistance and clonal outbreaks in hospitals with high mortality and difficult to eradicate with even strict infection control strategies. After 2018, one can see there is a increasing prevalence in hospital with this Candida parasilosis. The route to bloodstream is from translocation in gut because of mucositis in immunocompromised patients. Another route is through colonization of central venous catheters or contamination of total parenteral nutrition, and also in ascending infection leading to pyelonephritis. Endophthalmitis is an important complication of candidemia, and according to American Academy of Ophthalmology, there is just a rate of less than 1% in various studies, and the ophthalmoscopy is required only in symptomatic patients or patients who cannot report symptoms. In neutropenic patients, it is important to note that it manifests after 1 week of recovery of neutropenia. One very important thing is that echinocandin, which is the main treatment empirically used these days, does not cross the barrier and its intraocular concentrations are not adequate. Infective endocarditis is increasingly being reported as there is a rise in cases of candidemia. The risk factor for infective endocarditis are cardiac valvular surgeries, intravenous drug use, prolonged CVC use, prior bacterial endocarditis, and cancer chemotherapy. So, patient will present with persistent fever and changing heart murmur. There will be persistently positive blood culture. In these cases, echocardiography should be performed. And if prosthetic valve endocarditis is present, it should be replaced. So surgical replacement is important along with antifungal therapy. If central venous catheter is present and if it can be removed, it should be removed as soon as possible. But in cases of neutropenia, they also have thrombocytopenia. So there is a risk of bleeding involved. So that risk should be assessed before removing or replacing. The drug of choice here is liposomal amphotericin B, along with flucytosine if required. The treatment is prolonged for several weeks, and if the isolate is sensitive to fluconazole, patient is stable, then fluconazole can be used for step-down therapy, or in patients where surgical intervention cannot be done, it can be used for lifelong suppressive therapy. With surgery, there is an increased risk of embolic phenomena. Another serious manifestation is chronic disseminated candidiasis, which manifests as hepatosplenic candidiasis in neutropenic patients during neutrophil recovery. Patients present with PEO without candidemia and there is a complaint of right upper quadrant pain with altered liver enzymes. CT scan is diagnostic. Ocular candidiasis, it can be exogenously acquired or endogenous, and usually in 90% cases Candida albicans is responsible, and in 10% cases Candida tropicalis is responsible. Other Candida species are not able to cross retina. So dilated fundoscopy should be done, and based on the assessment, vitreal aspirate is uh, sent to the lab. Laboratory diagnosis broadly, microscopy, uh, which will be providing information about budding yeast cells, pseudohyphae, and presence of hyphae. Culture remains mainstay because antifungal susceptibility testing is required. But culture gives results after 48 to 96 hours. The Candida glabrata, which is showing so much resistance to commonly used drugs, takes further 24 hours. Serological markers are of negative predictive value, and they can be used at times when there are no other tests available. Direct detection in blood samples will reduce the mortality and is very important for antifungal stewardship. Direct detection in blood by PCR, by BioFire, or T2 Candida panel in 4 to 5 hours is very important but very limited availability, and it's very expensive. Only in developed countries it is available. But seeing the high mortality of almost 50% and culture positivities again is only in 50% cases of candidemia. So these diagnostic facilities are being explored and being increasingly used with better drugs available for candidemia treatment. So echinocandins remain the mainstay for treatment according to EASA 2016 guidelines, and they can be used for initial 5 to 7 days. And once patient is stable and blood culture has turned negative, then if patient has no prior exposure to azoles and uh, on AFST isolate is sensitive to fluconazole, then fluconazole can be used for step down therapy for 2 weeks in routine. If patient is stable and there is no prior exposure to azoles and the prevalence of azole resistance is less than 7 to 10%, then fluconazole can be used as first line therapy, because echinocandins are very expensive, and in developing world it cannot be afforded by many patients. But at the same time, these are the areas where fluconazole resistance is reaching 50 to 70%, especially in non-albicans Candida. Another agent is liposomal amphotericin B, but it carries high toxicity. Voriconazole can be used where anti-mold prophylaxis is also required. In neonates, amphotericin B deoxycholate or fluconazole still remain relevant because of low toxicity, and fluconazole has better penetration in CNS. When CNS or CVS are involved, then liposomal amphotericin B remains the drug of choice. with or without flucytosine, and it needs to be used for months. And if there is any prosthetic device, if it can be replaced or removed, it should be done. Urinary tract candidiasis. So asymptomatic patients usually don't need any treatment and they resolve spontaneously, except in low birth weight infants, in neutropenic patients, and before any urinary tract manipulation, asymptomatic patients need treatment. If there is cystitis or pyelonephritis, then fluconazole 200 mg should be used for 2 weeks. If we are suspecting fluconazole resistant isolates like Candida glabrata or Candida krusei, then amphotericin B deoxycholate can be used. It can be used for 1 day to 7 days, and then it can be replaced with flucytosine for 2 weeks. Remember, liposomal amphotericin B has no role for lower UTI. Ocular candidiasis is treated with fluconazole or voriconazole or liposomal amphotericin B. Intravitreal amphotericin B deoxycholate or voriconazole can be used. In some patients, vitrectomy is required. Remember, echinocandin has no role in ocular candidiasis. Vulvovaginal candidiasis, for mild cases, fluconazole single dose is enough. But for recurrent or severe infection, 3 doses can be given 72 hourly. If Candida glabrata is responsible for vulvovaginal candidiasis, then boric acid gel capsule can be used for 2 weeks as local application. For recurrent disease, fluconazole 150 mg can be given weekly for prolonged period. So with the availability of echinocandins, which have less toxicity, less drug-drug interaction, and 50% of the blood cultures are not detected with candidemia, it is our duty to identify those patients with high risk factors and such high mortality and such high prevalence to save them. I hope this talk helps you in identifying these cases. Thank you.